Hello, my dear students. A very good evening to all of y'all. I am Dr. Anaya Kulkarni, your guru for the subject of pedodontics. And here I am to take the discussion for you of some previous year questions of pedodontics. Okay, so I've selected a set of questions that I think will cover a lot of important topics, and while we discuss it, a lot of other concepts for you will also get clear. Okay, so let us begin with the first question for the session. And the first question for the session is, what percentage of SDF is used for anti-caries effect in dentistry? So first, what is SDF? SDF means silver diamine fluoride. Okay, so silver diamine fluoride is something that is used basically to arrest active caries. What does it do? It arrests active caries. So it is arresting the active caries, and hence the active caries, and hence it is of great importance in what you call as in children, because children will not always let you remove all the caries. They will not let you use an aerator perfectly. They will not let you use a hand instrument to remove all the caries. So a component that actually arrests some part of the active caries which can be left behind due to the uncooperative patient is actually helpful, and such a compound is SDF. Okay, it is a fluoride compound that is primarily used in the prevention and management of dental caries in children, particularly those who are having high risk of cavities, and in areas where also it is difficult to access for clearing up all the active caries. Now, silver diamine fluoride is commonly available in a concentration of 38% for dental use. So, the answer here becomes 38%. So, it is available in 38% for dental use. The percentage refers actually to the concentration of the active ingredients of the solution, that is silver, fluoride and ammonia. Okay, so what all do we have here? We have silver, we have fluoride, and we have ammonia. Okay, so the concentration of these three elements basically is 38%. So silver will do what? Silver will help to kill the bacteria. Silver has an antibacterial effect, and it prevents further bacterial growth that contributes to the tooth decay. Okay, what does fluoride do? Fluoride helps in remineralization of the enamel, making it more resistant to acid attack from the bacteria, and it reverses the initial stages of dental caries. Again, we have ammonia, which helps to stabilize the silver and fluoride in the solution. Okay, so basically all three of them combined are present in a 38% concentration. So it is well researched and balanced concentration that provides effective anti-caries effect without being too harsh for the dental tissues like the gingiva, oral mucosa, teeth, etc. Okay, so this is the percentage of SDF that is used for the caries. Right. The second question that we have here is, what is the composition of KRI paste? Okay, so KRI paste is what? It is an obturating material that is used in primary teeth. So primary teeth obturating material. Right, that is KRI paste. KRI does not have a expanded form. It's not an abbreviation to anything. Okay, it's the name of the paste that has been given by the brand, that is the KRI paste. So what exactly is the composition of the KRI paste? The KRI paste is composed of parachlorophenol, iodoform, menthol and camphor. Okay, so there is parachlorophenol, iodoform, menthol, and camphor. So the option C here is the correct answer. So KRI paste is known to be the ideal obturating material. So what is it? It is an ideal obturating material. Okay, it is typically used for infected pulp or in cases of pulpotomy and pulpectomy in children, particularly when the pulp is compromised but the tooth can still be retained. So you do a pulpectomy or pulpotomy and there you can use the material that is KRI paste, right? So this is the composition of the KRI paste. The third question is, pulp capping agent of choice in pulpotomy is what? So very quickly, let us just revise what exactly is pulpotomy. So this, my dear children, is your tooth. So this is your tooth. These are the roots of the primary tooth. And then inside we have the pulp in blue color, say. So this is the pulp. Okay. Now you have caries that are, for example, up till here. Right? So the caries are just, they are just touching the pulp. Okay, they've just reached the pulp. So what do? You start excavating the caries. So when you start excavating the caries, you have a little pulp exposure. So this is the pulp exposure that has happened. Okay, and now that there is pulp exposure, you do what? You decide that, okay, the pulp exposure is greater than pinpoint. So whenever there is just pinpoint pulp exposure, you go for a direct pulp capping. Now, because the pulp exposure is because of caries, the caries had involved or touched the pulp. That means the infection from the caries has been transferred to the pulp at maybe at a different level. Maybe the entire pulp is involved, or only the coronal part is involved, or even only the half of the coronal part is involved. So what do? You expand the cavity. So you expand the cavity. You dig into the entire pulp. So you dig into the entire coronal pulp. So this is how you do it. You are forming a cavity. You are digging into the entire coronal pulp. And then you use a cotton pellet dipped in saline and you place it over the root stumps, the pulp stumps that are present in the root. So after you just remove the cotton pellet, you see that the bleeding from the root stumps has arrested. The radicular pulp bleeding has arrested. That means the radicular pulp is healthy. Now you decide that there is no need of pulpectomy because the radicular pulp seems to be healthy. The bleeding has arrested because a profusely bleeding pulp will be infected. If the bleeding has arrested by placing a cotton pellet, that means the radicular pulp is absolutely healthy. So you can preserve the radicular pulp, right? So now that you can preserve the radicular pulp, you go for a procedure called as pulpotomy. So for pulpotomy, what do? You place a material such that this particular area is sealed. So you want to seal this particular area so that your radicular pulp stumps are not disturbed. Okay, so such a material you need to use for completing your pulpotomy. So the ideal or the pulp capping agent of choice, or the ideal, let's say ideal material that can be used for pulpotomy is MTA. So the answer here is MTA. What is MTA? MTA is mineral trioxide aggregate. So that's the material of choice. It is a biocompatible material that has become the gold standard for pulp capping in pulpotomy procedures in pediatric dentistry. Okay, so basically what does it do? It is a material which has a composition like Portland cement, and basically it helps to maintain the health and vitality of the remaining pulp, allowing the tooth to function naturally, and it exfoliates naturally. naturally eventually. Okay, so the material sealing ability and low inflammatory response reduces the chance of tooth loss, infection, and abscess formation. So this is very important for maintaining the patient's overall oral health and ensuring that the tooth can remain in place without additional treatments. So here the pulp capping agent of choice is what it is. MTA, that is mineral trioxide aggregate. What is super EBA? So super EBA is super epoxy based amalgam. That is super EBA. Okay, so super EBA is another commonly used material for pulpotomies, especially for permanent teeth, but it is not the material of choice in pediatric pulpotomies. Super EBA has some biocompatibility issues and does not promote dentine formation just like MTA does. Okay. While it is effective at sealing the pulp and reducing bacterial leakage, it does not stimulate hard tissue regeneration as well as just like MTA. Therefore, MTA is preferred for its ability to support the healing of the pulpal tissue. Okay, so similar is fast setting calcium hydroxide and slow setting. So calcium hydroxide is a material that has been historically being used. However, fast setting calcium hydroxide has some drawbacks. So what are the drawbacks of the fast setting calcium hydroxide? It has high solubility and low sealing ability. Over time, it may dissolve and lead to bacterial infiltration because of such a property. Okay, whereas slow setting will be basically it has lack of sealing ability and it has greater micro leakage. It can lead to micro leakage, and that is why MTA is supposed to be the ideal or the material of choice for pulpotomy procedures. Let us now hop on to the question number 4, which is, what is mesial step molar relation in primary teeth? So when we look at the primary teeth, when we want to determine the occlusion, we always look at the primary second molar. We do not look at the primary first molar. We look at the relationship of the upper and the lower primary second molar. Okay. Yes, and that is yes. So primary second molar is basically seen the upper and lower. Now there are 3 types of molar relations. So this is 1, this is 2, and then we have the third one like this. So the first one, as you all can see, forms whenever you track the distal surface of the second molars, you see a plane forming. So when the plane forming is a straight line, that means it is a flush terminal plane or an end on. Okay, then if you track it and you see a step that is being formed on the mesial towards the mesial side, that means it becomes a mesial step. So it becomes a mesial step molar relation. And then if the step is forming towards the distal side, so it forms the distal step molar relation. Okay, so what they've asked is mesial step molar relation. So that means the distal surface of the, so this is the distal surface of the lower molar is present more mesial to the upper molar. So distal surface of the lower second molar is, second primary molar is more mesial to that of the upper. So the answer becomes C. Okay, so these are the 3 types of molar relations that we see in primary teeth. Correct. Now we come on to question number 5, which is, how can one diagnose the initial caries, that is ICDAS score 1. So ICDAS score, you've read, in my lectures I've shared the various tables of ICDAS scoring. What is ICDAS? It is International Caries Detection and Assessment System. So when we see the score 1 of ICDAS, it basically refers to the earliest stage of tooth decay, where there are subtle changes in the enamel structure that are visible to the naked eye. These changes may not be apparent under normal conditions, but become visible when the tooth is dried or wetted. So basically in such a tooth the demineralization has occurred, but it is not so frank, or it is not to such a degree that it will be seen without or it will be seen to the naked eye. For you to clinically appreciate an ICDS score 1, you need to dry the tooth so that the demineralized part stands out. Okay, so the answer here is ICDS score 1 is what? It is the first visual change that is seen by drying or wetting of the tooth. The answer is A. Right? Okay. The next question, that is question number 6, is thumb sucking habit is considered normal till what age? So the thumb sucking habit is considered normal until the age of 4 years. Okay, so basically thumb sucking is generally considered normal up to the age of 4 years. And up till this time, basically there is no malocclusion that is happening. Okay, just let me open the link if you have any questions for me. Yes, okay, no questions as yet. Okay, somebody asked me about the composition of the KRI paste percentage. Yes, please go through the composition, including the percentage of the materials, percentage of the individual materials that are present in it. Calcium hydroxide is used in which case? Calcium hydroxide was actually used as a gold standard material. It was used in pulpotomies and DPCs, but because of certain drawbacks, they developed a material like MTA. So you can use calcium hydroxide in pulpotomies, but better than calcium hydroxide is MTA. Okay, done. Only 2 questions so far. So until 4 years of age, there is no deleterious habits, there is no deleterious effects happening to the oral musculature of the child. So until 4 years of age, it is considered to be normal. After that, you need to intervene. Okay. The next question, that is question number 7, is a procedure in which the exposed pulp is covered with a material to enhance reparative dentine formation over the pulp, which is exposed by caries, or so it is exposed by caries or mechanical exposure. So what will it be called? So it is actually what? It is direct pulp capping. Okay, so there is a mechanical exposure, the pulp is exposed and it is covered with them. So this entire definition is what? It is the definition given for direct pulp capping. Direct pulp capping is a dental procedure performed when the pulp of the tooth has been exposed to the dental caries, okay, or dental caries or mechanical trauma, but there is no evidence of irreversible pulpitis. Only a pinpoint exposure has happened such that even the coronal part of the pulp is healthy, so you call it a direct pulp capping. Right? Yes, direct pulp capping. Even if there is biodentine pratishtha, even then you are going to go for MTA as the ideal material for pulpotomy and DPC. Okay, biodentine is also used, but MTA is the gold standard now. MTA is the choice material now because it forms the strongest dentine like material, the strongest barrier with no micro leakage at all. Okay. Operational procedures in a child as young as 2 years has to be in the supine position. More than 2 years, it has to be in the semi-supine position. Who has asked me? Chinmay. So you must know the age of the child there. If the child is 2 years or younger, so you take the child in a supine position, lap to lap position, and if the child is older than 2 years or 3 years, then you take him in the do the procedure in the semi-supine position. First dental visit of the child should be at 6 months. Okay. It should be at the age of 6 months. Right. The next question, that is question 8, is what? Yes. So question number 8 is, what is the indication of the lingual arch appliance? Okay. So you all know what is a lingual arch appliance. So these are the teeth. Sorry for the beautiful diagram that I'm making. So lingual arch appliance, you have two bands over here, and then there is a wire component that runs through like this. So this is the lingual arch. So what is the indication? Okay, Chinmay, if the age is not mentioned, you go for a semi-supine position there. Okay. Yes, though it will be always good if they mention the age there, but if not, semi-supine, right? So this is the lingual arch. So what is the indication? It is multiple mandibular molars which are decaying and needs extraction. So if you had to extract this particular tooth and this particular tooth and say this particular tooth, then you go for a lingual arch. Though there is one particular thing about lingual arch, and that is the anterior component of the lingual arch actually rests on the lower anteriors, and that too on the permanent anteriors. So in case the child is so young that the permanent anteriors have not erupted, so in a case where there is primary incisors are present, you do not give a lingual arch, you give a bilateral band and loop, but you do not go for a lingual arch. You give lingual arch only in case there are permanent anteriors that have been erupted. Please always remember this in case you get a similar question. Now, question number 9 says what? A 3-year-old child has delayed developmental milestones, difficulty in learning, always plays in isolation. He's brought to a doctor with oral myiasis. What is the diagnosis? Okay, so all of these 4 options seem similar. Okay, yes. In deciduous teeth, can we do revascularization or regeneration? Pulp therapy will not be successful. Primary teeth, revascularization, regeneration, no need also. You know, there is a very fun concept. As soon as the root formation of the primary tooth is complete, the resorption of the primary tooth begins. You know, that's actually true. And then what will you do by doing revascularization of the primary teeth? There's no actual need. Okay, so you go for revascularization and and regeneration in permanent teeth only, right? Yes. So here in this particular question, the answer is specific learning disorders. Okay, so basically in case of autism, in case of mental retardation, and in case of ADHD, what will be different? In case of autism and mental retardation, there will be inability in learning, not difficulty. Okay, so in case of autism and mental retardation, there will be inability in learning things and not difficulty. Okay, yes. In case of ADHD, a child will never play in isolation. Okay, so these are very small. I am always very skeptic about this particular question. This PYQ has come across a lot of times. A lot of you ask questions about this, but very, you know, it's all very similar, but the best answer out of all the 4 answers is specific learning disorders. Okay, so what is specific learning disorders? These are neurodevelopmental disorders that are typically diagnosed in early school age children, although may not be recognized until adulthood also. They are characterized by persistent impairment in at least one of the 3 major areas, that is reading, written expression, or in math. Okay, so if the child is actually having difficulty in either of these, you can call it a specific learning disorder. Okay, so the answer here is specific learning disorder. Let us now come to question number 10, which is few days after birth, a child is brought to the clinic with oral ulcer near a tooth-like structure in the mandible. What is the condition? So basically what happens, sometimes there is something called as the natal tooth or the neonatal tooth tooth, correct? So what is this? Natal tooth is something that is present at the time of birth in a child, and neonatal tooth is a tooth which occurs after a month of after 1 month old the child becomes. Okay, So whenever such a tooth is present, it keeps hurting the lower side or the ventral side of the tongue, and there is an ulcer that forms, and this particular is called as the Riga-Fed disease. The answer is A, Riga-Fed disease. Question number 11. So question number 11 is, leeway space of Nance is, what is the leeway space of Nance? So there is a particular time when you have the primary first molar, the primary second molar, and the primary canine, and above these teeth is present the premolar, second premolar, the first premolar, and the permanent canine. So what happens? The width of this is like this. Okay, so the space occupied by the permanent, these three permanent teeth is lesser than the space occupied by the primary teeth there. So the difference in space is called as leeway space. Okay, so difference in the width of the primary canine and molars and that of the permanent canine and premolars is called as the leeway space. The answer is B, that is leeway space. Just give me 1 minute. Just by curious. Okay, so very good question here we have. If there is caries exposure, can we actually go for direct pulp capping? Theoretically, no. Okay, yes, so you cannot go generally whenever there is a caries exposure. Most commonly you will have a part of the coronal pulp that can also get infected, but if the caries have just involved the tooth, so you know, again what you do whenever you have a pinpoint exposure, you try to arrest the bleeding. If the bleeding is arrested, that means the coronal pulp is healthy. If you are not able to arrest the bleeding, that means you have to go for pulpotomy. In case of caries exposure, most commonly you'll have to go for pulpotomy, but there are cases where you can still do DPC, where the bleeding gets controlled and you get signs that there is no inflammation in the coronal pulp also. Yes, in specific learning disorders, you actually encounter poor oral hygiene maintenance. You actually encounter that, right? Then there is compromised nutrition, everything that can lead to oral myiasis, right? So 11th question done there. Now we come to question number 12. Which of these analysis does not use mandibular incisors? Okay, so you all know this is model analysis. You do an analysis of the cast in order to understand whether the space available is appropriate for the teeth that are yet to come. So you actually compare the space available and space required, and that is how you understand whether there's going to be a malocclusion or not. Okay, so the answer here is Hookabah's analysis. Okay, so Hookabah's analysis is the one that does not use the mandibular incisors. So Hookabah's analysis was actually recommended by Hookabah GW in the year 1964. It compensates for the radiographic enlargement of the tooth image in the periapical film. It is based on the assumption that the degree of magnification of a primary tooth will be same as that of the underlying permanent successor on the same film. So, the Hookabah's analysis is actually a radiographic analysis. Okay, so it is basically a radiographic analysis. It does not have a predictability chart, whereas the other three are based on predictability chart that is actually looked at after determination of the width of the mandibular incisors. Okay, so Hookabah is basically a radiographic analysis. Coming to question number 13. So tooth 6-1 shows which stage of ECC. So what stage of early childhood caries? What stage of early childhood caries is seen in this particular picture? Okay, so the answer here is C, moderate, because in very mild you will basically you will not be able to see any frank visual changes. No frank visual changes will be visible. Only demineralized some part of the tooth will be seen, which will stand out only when the tooth is dried. That is very mild. Then we have mild, where you will see opacities, white opacities that can be seen, that is mild. But when you have brownish discoloration and a slight, cavitation also, but the tooth is not completely disfigured or destroyed, that means it is moderate. So the answer here goes is C, moderate. Question number 14. So question number 14 is what? What is happening to this child that is shown in the image below? Krati, in severe ECC, you will see complete destruction of the crown structure, just like in this particular case, So that's not severe ECC. That is moderate ECC, where the tooth structure is still present. It is not completely destroyed. Okay, this child just had one visit to the children dental facility. So what is happening to this particular child? Why is there black discoloration? So the black discoloration is due to the SDF application. What is SDF? SDF is silver diamine fluoride, which leads to black discoloration of the tooth. It does arrest the caries, but it actually leads to black discoloration of the tooth. So nowadays there is silver diamine fluoride, which has potassium iodide incorporated in it, and the potassium iodide does what? Potassium iodide does not let the tooth to stain. So whenever you get a question, what should be added to silver diamine fluoride to prevent the staining occurring because of it? So it is potassium iodide that can be added to silver diamine fluoride. So this particular bottle where you have potassium iodide incorporated silver diamine fluoride is very, very expensive. So basically most of the time you use silver diamine fluoride, and you actually tell the patient that it is going to act the same, but it is going to be aesthetically not so pleasing. But if the patient can actually afford a costlier treatment, you can go for potassium iodide incorporated silver diamine fluoride. Okay. Now we come to question number 15, which is, what is the material of choice for pulpotomy in primary tooth? So this is a repeat, I think. So you all know it is MTA. MTA is the material of choice for pulpotomy. Question number 16 is, which of these agents is given to the child via the nasal route for a procedure on the dental chair? So you all can see a picture. What is being given to the child via the nasal route? So it is, as you all know, he is undergoing a procedure under conscious sedation. So for conscious sedation, what do you give? You give nitrous oxide through nasal route. Okay, so that is conscious sedation, and there's a mask through which you're giving nitrous oxide. So basically the whole setup comes with two cylinders. One, you have oxygen filled in it, and one, Krati, I am going to explain it to you later after the session is over. I'll reply to you in the messages. Okay, yes, so there are two cylinders in this whole setup, where in one cylinder you have nitrous oxide, in the other cylinder you have oxygen. So you flush 100% oxygen first via this particular mask, and then you keep titrating 10%, keep increasing 10% of nitrous oxide wherever you feel that the child is feeling euphoric, the child is relaxed, there is anxiolysis. You stop increasing the percentage of nitrous oxide, and the child very happily gets the treatment done. The maximum amount of nitrous oxide that you can pass through a child is, so you can, the ratio in which you can do is, maximum is 40% nitrous oxide and 60% oxygen you still have to keep. That's the maximum, though most of the children get the effect in 30% nitrous oxide only, right? Okay, the question number 17 is, Okay, so what they've asked is which of these agents is given to the child via the nasal route for a procedure in the dental chair. So basically, the agent that is given is nitrous oxide. Oxygen, so he's anyways getting na. Oxygen we give. It's like an emergency management for us. Okay, oxygen. We are not deliberately giving. Oxygen is not an agent there. Okay, that is helping you with the treatment. The agent that is causing conscious sedation is nitrous oxide. That is why you go for nitrous oxide. Is it clear? Why not C? Okay. Hopping on to question number 17 is what is the amount of fluoride in Durafat? So what is Durafat? Durafat is a fluoride varnish. So Durafat is a fluoride varnish, right? And the amount of fluoride in Durafat is 22,600 ppm. The answer is A, 22,600 ppm. So Durafat contains 22,600 parts per million of fluoride. This high concentration is significantly greater than that found in the over-the-counter fluoride toothpaste, and that is why this can be used for patients who are more prone to caries. Right? Okay. Then we come on to question number 18, which is, as per the American Academy of Pediatric Dentistry, which of these is not a type of pulpitis in primary dentition? So what they've asked is, which of these does not occur in primary dentition? So you have four options: acute reversible pulpitis, irreversible pulpitis with pulpal necrosis, irreversible pulpitis without pulpal necrosis, acute irreversible pulpitis. Okay. So basically this particular option is what, when this particular thing happens in permanent teeth, what we call it as hot tooth condition, where the caries has just touched the pulp. It has just touched the pulp, and the tooth is, there is a severe toothache, though the entire pulp is not inflamed. There is no pulpal necrosis that has occurred. But this particular thing does not occur in pediatric patients, does not occur in primary dentition. Wherever there is irreversible pulpitis, you will find only pulpal necrosis. A child will not report to you with hot tooth syndrome because the nerve fibers, the A delta nerve fibers that are present for that are responsible for the severe tooth pain are basically underdeveloped in primary tooth, and hence no child is going to report to you in a condition where there is irreversible pulpitis without pulpal necrosis. A child will always report to you with pulpal necrosis that has already occurred. So the answer here is C, irreversible pulpitis without pulpal necrosis. The answer is C. Okay. Coming on to the next question, that is question number 19. A siren-like cry of a child with no tears. So we've read it a lot of times during our lecture. That is, a siren-like cry of the child with no tears is called what? So the answer here is it is obstinate cry. Okay, the answer here is obstinate cry. So obstinate cry is a loud, high-pitched and characterized like a siren-like wail. There is a pause and then it is repeated all over again. Okay, so the answer is A, obstinate cry. You all know what is compensatory cry. It is not a cry at all. It's just making some sound so that the fear of the surrounding sounds is drowned out. Okay, then there's a fearful cry, and then none of the above is not the answer. So the answer is A, obstinate cry. The next question is identify this particular appliance. Okay, so you all will get confused whether this is for tongue thrusting or this is for thumb sucking. So basically all the appliances, most of the appliances that are used for tongue thrusting are actually also used for thumb sucking. So whenever you get such a question, whenever you have a tongue crib or a tongue rake that is present, you always first go for the tongue thrusting as the answer. So this is a tongue crib over here, and it is a fixed appliance, fixed habit breaking appliance for tongue thrusting. The answer is tongue thrusting. Okay, yes. Question number 21. The first tooth affected in the dental caries is in ECC is which one? So the first tooth that is affected is always a maxillary central incisor. It is always a maxillary central incisor. So maxillary incisors are typically affected in infants with ECC, followed by the maxillary and then the mandibular molars. The mandibular incisors are frequently spared because of the protective nature of the tongue that is present. So the mandibular incisors are known as the immune teeth of the oral cavity. Clear? Yes. So the answer is maxillary central incisors. Right? Okay. The next question, that is question number 22, says what? Which of the following is wrong about gum pads? Okay, so you know what is a gum pad. Gum pad is basically present in the predentate period of a child. So before the eruption of the teeth, the gums are called as the gum pads, and this is the gum pad. Gum pads are basically horseshoe in shape, and then when we look at the gum pad, here is the incisive papilla. Then there is a gingival groove basically that differentiate separates the rest of the oral cavity with the gums. Then there is a groove that runs all through the gum pad, which is called as the dental groove. Okay, then we have the transverse grooves, which actually divide the gum pad into 10 sections for the 10 tooth buds to come. So this is the transverse groove, and in the canine area the transverse grooves are called as the lateral sulcus. So this is the gum pad. Okay, yes, so the answer here is yes, so we have the moksha, we have the gingival groove, there is a dental groove, then we have a lateral sulcus, then we have lateral sulcus which are present in the canine region, then we have the transverse grooves, and there is an incisive papilla. Okay, now the options that have been given are transverse grooves are 10 in each arch. Okay, so what options they've given you is the transverse grooves are 10 in each arch. The dental groove divides the palate and the gum pad, or the maxillary and the mandibular gum pads are come in contact in the posterior region, and maxillary is in horseshoe shape. So all of them are correct, but this one is wrong. As Moksha just said, it is the gingival groove that divides the palate and the gum pad. They've given dental groove, so which is wrong? The option number B is wrong. Okay, coming on to question number 23, we have okay, so we have question number 23, that is difference between primary and permanent teeth is. So 4 options they've given, 4 sentences they've given, statements. Furcation area accessory canals are more in primary teeth, yes. Thin enamel and dentine in primary, yes. Root trunks are longer in primary, no, the root trunks are very small, they are shorter. More developmental grooves in mamelons, no, mamelons are not present in the primary, so that is why the answer is A and B. Statement number 3 is wrong, the root trunks are shorter, and statement number 4 where they say mamelons are always present in permanent incisors, so that's also wrong. So option number A and B, so this is correct and this is correct, so option B is correct, right? Okay, yes. So good so far. Now we have question number 24 that says, which is incorrect pit and fissure? Which is incorrect about pit and fissure sealants? So what they've given is Remineralizes the smooth surface. So remineralizes the smooth surface caries and white spots. It remineralizes the smooth surface caries and white spots. Remineralizes incipient caries and occult caries. Yes, it does. It remineralizes the incipient caries and occult caries. Sealant wears Sealant wears off slowly from maxillary teeth and faster from the mandibular teeth. Yes, that's correct. If it is lost within 3 months, if it is lost within 3 months, it is due to the operator's preparation. Yes. If it is lost after 3 months, it can be due to maxillary stress. Yes. So what they've asked is the incorrect statement. So the incorrect statement is only the A one. That's the only incorrect, because in the smooth surface caries and white spots, you never put pit and fissure sealants. Okay. Yes, if it is lost after 3 months, it can be due to the masticatory stress, Moksha. That's the correct answer. But what they've asked you is the incorrect statement about pit and fissure sealants, and that is undoubtedly A. On the smooth surface and on the white spots, you never put pit and fissure sealants. So there is no remineralizing happening there. Now we come on to the pre-operational next question, number 25. That is, okay, is it lagging? I think it is lagging. Acha, okay. So here the answer is B. Sorry. Yes, they've given the option. The answer is B. Only statement number A is wrong there. The one that I've ticked with the blue. Okay. Yes. Right. So pre-operational stage in the Piaget's theory of cognitive development is around. So the pre-operational stage is 2 to 7 years. The answer is 2 to 7 years. So there's a pre-operational stage. There is first is sensory motor stage, that is birth to 2 years, pre-operational 2 to 7 years, concrete operational 7 to 11 years, and formal operational, that is ages 12 years and above. Okay, so they've asked pre-operational. The answer is A, that is 2 to 7 years. Question number 26 is material that is not used for pulpotomy. So which material is not used? Maisto paste is not used for pulpotomy. Okay, maisto paste is what? It is an obturating material. Okay, so you can use MTA, you can use glutaraldehyde, ferric sulfate, all, but maisto paste is an obturating material which is used in pulpectomy. It consists of para-chlorophenol, camphor, menthol, iodoform, zinc oxide, thymol, and lanolin, and it is used as an obturating material in the root canal of primary teeth. Question number 27. During behavior management for fearful child, systematic desensitization means. So what is systematic desensitization? Slowly and steadily increasing the severity of the disease. That means you first just do an oral screening, then second you just do a hand scaling, then you start with cavity drilling. So eventually, step by step, you're increasing the intensity of the treatment, and that is called as systematic desensitization. So that is stepwise gradual exposure to fearful things. Okay, so that is stepwise gradual exposure to fearful things. It was basically introduced by Joseph Wolpe. In the year 1975, and it works on the principle of classical conditioning, that is slowly and steadily, the patient gets the hang of the dental treatment, and eventually he cooperates. The next question is, which type of space maintainer is shown in this particular picture? So you all can see there is something that is bilaterally placed, and what is this? There is a band over here, there is a loop over here, so it becomes a band and loop space maintainer. So the picture shows a band and loop space maintainer which is bilaterally placed. It is a bilateral band and loop space maintainer. Okay, so it is basically given in case of early loss of primary teeth, right? Then we come on to question number 29. In molar incisor hypomineralization case, the restoration keeps on failing due to what? So why does the restoration keeps on failing in case of MIH? Okay, so a tooth that has molar incisor hypomineralization is less mineralized. Okay, it has less mineral content, because of which it looks mottled, destroyed. Okay, that is, it looks hypomineralized, right? That is molar incisor hypomineralization. So the restoration will not be retained in such type of tooth because of the irregular enamel structure. Okay, so because of the hypomineralized weak enamel, the tooth will become crumpled, the tooth will look crumpled, and because there is no strong enamel to retain the restorative filling, it will it will keep on dislodging the restoration again and again, right? Yes, the answer there is A. The next question, that is question number 30, is silver modified atraumatic restorative treatment. The silver particles that are used are which one? Okay, so the in case of the SMART treatment, the silver particles that are used are basically the silver diamine fluoride, that is B. Okay, silver diamine fluoride contains approximately 24 to 28 percentage of silver. So this much percentage of silver is present. Yes, and 5 to 6% of fluoride is present in case of silver diamine fluoride. Okay, the silver diamine fluoride, that is SDF. Then basically oral absorption can include absorption in the mucous membrane in the mouth and the nasal cavity in case of SDF. The main advantage is the aesthetic result, because as I told you, it permanently blackens the teeth, and that is the main disadvantage. Otherwise, it has excellent results in arresting the active caries lesion. So what is atraumatic? You all know what is atraumatic restorative treatment. Atraumatic restorative treatment is the one where you use only hand instruments. So it can be done in cases where you are doing treatment camps in remote areas where probably there is no accessibility to electricity, or you do not have sufficient rotary instruments, or you have a lot of patients that you're supposed to treat. So in such treatment camps, you do atraumatic restorative treatment where you remove the caries how much ever is possible with the help of hand instruments, and you restore them with a material, one that will help in arresting active caries that can be left behind, and two, materials that can stick to the tooth structure such as GIC. Okay, so that's one condition for ART. Second condition, you do it in children who are very, very uncooperative or fearful because of the loud sound of the aerotor, etc. So where the child is not allowing you to use the aerotor, you can go for ART, that is use of hand instruments only. Right? Yes, spoon excavators are used. Question number 31 is what? During class 1 cavity preparation of mandibular second molar in a 6-year-old child, the child complains of a sudden sharp pain which reduces after a few seconds. What should you do? So basically, a sudden sharp pain says that you have exposed the pulp, and because you were not expecting the pulp to expose, that means there was no radicular pulp that is involved. There is sudden sharp pain, that means the coronal pulp is inflamed. So that means you have to inform the patient and do pulpotomy. Okay, so sharp pain means inflammation of the pulp, and subsiding after a few seconds, that means the radicular pulp is unaffected. There is something wrong with the coronal pulp only. So you inform the patient and you do pulpotomy. Direct pulp capping nahi hoga because there is sharp pain. You do direct pulp capping only when you are sure that no part of the pulp is inflamed. Okay, there is sharp pain, that means the pulp is inflamed. So in that case, you cannot do direct pulp capping, you have to do pulpotomy, right? Okay, now you come on to the question number 32. Which one among the following has been most helpful for motivating the parents to prevent the caries in a child? Okay, so how do you prevent the caries in a child? So whether it is a psychological counseling or result of caries activity test or chairside intervene motivation or self-readable booklets or the parents. So basically the most effective according to a particular what do you call as research is the chairside intervene motivation. Okay, so chair side intervene motivation has been the most effective, and the answer is C, chair side. Yes, it can be done, Moksha, in accidental exposure, but in case where there is no pain, pain equals to inflammation in the pulp, and you cannot leave inflamed pulp inside because they've mentioned sharp shooting pain. That means there is inflammation, and that means you have to remove the inflamed pulp. That means direct pulp capping is not going to work. You have to go for pulpotomy. Okay, Moksha, I hope you've understood. Question number 33. Identify this particular appliance. So you all can see this is a maxillary arch over here. Okay, so maxillary arch hai, there is posteriorly the band has been applied. Okay, and there is something that is coming in front, and there is replacement of the teeth here. So this is what this is a Groper's appliance. What is Groper appliance? Groper's appliance is basically used in order to replace the prematurely lost anterior teeth. So it basically maintains the space, but more than maintaining space, it actually replaces the anterior teeth. In the anterior, if there is premature loss of the teeth, the space loss does not occur in anterior teeth. Okay, but you have to replace the anterior teeth, you have to place them again, because anterior teeth loss can result in the speech development of the child. That is why you need to replace the anterior teeth. Also, it prevents the tongue habits, otherwise the tongue will keep propping into the empty space, and the child will develop tongue thrusting. So one, in order to prevent tongue habits, and two, in order to have proper speech development, you give Groper's appliance, which replaces the anterior prematurely lost teeth. Right? Question number 34 is, what is shown in this particular picture? So in this particular picture, what you see is lateral luxation. So why is it not intrusive luxation? Because the size of the tooth seems to be the same. Okay, in intrusive luxation, the tooth will go inside, so the size of the tooth will look smaller because it's gone inside, but the size of the tooth is same. That means the tooth has been luxated sidewards. Okay, so that means it has become lateral luxation and not intrusive luxation. And it's not subluxation, because in subluxation the tooth does not change its place at all, but the tooth has been shifted from its place. That means it is some sort of a luxation. So between lateral and intrusive, if it would have been intrusive luxation, the tooth would have become smaller in size because it would have gone inside, but this is lateral luxation, right? Okay, unilateral, so they've written like that only, Pavan. It's actually on one side only you will replace. Why unilateral they've given, I don't know, but it is Groper appliance, so you go with the entire option. Now we come on to the last question of today's session, which is, which of these is not a risk factor for dental trauma? So which of these is not a risk factor for dental trauma? The options given is proclination of incisors. It is a risk because the teeth will be proclined. If a child falls, the dental trauma to the proclined teeth will be very quick. So that is a risk for dental trauma. Increased overjet, same as proclination of incisors, है ना? Increased overjet, so it will be a risk for dental trauma. Then short upper lip, again the incisors will become very very prone to injury if the upper lip is short. But having physiological space, there is no problem with the trauma. Physiological space, absolutely okay with the trauma. There is no risk factor for dental trauma in case of physiological space. The answer becomes C, physiological spaces. So with this, we complete the previous year question discussion. I hope you understood all the explanations to all the questions. I've tried to cover the important topics of pedodontics. And if you have any doubts, come to me at the Telegram group or the WhatsApp group and we'll solve the doubts. And please do go through the live lectures, the material that is available on the DBMCI app for you, and we are there to solve all your doubts. And thank you so much for being such good students, good listeners. Thank you so much. Bye bye. Good night.